to the webinar Leveraging Partnerships for a Community-Based Fall Prevention Strategy, facilitated by the Fall Prevention Community of Practice. My name is Christina Chico, and I am a project coordinator at the Ontario Neurotrauma Foundation. ONF sponsors the Fall Prevention Community of Practice and its online platform called Loop. Loop is a place where fall prevention practitioners connect. You can visit us at fallsloop.com. Marguerite Thomas also joins us on the line. Marguerite is the coordinator of the Fall Prevention Community of Practice and will be assisting with the webinar technology. Before we begin, I'm going to give you a quick review of the webinar technology we are using today. This webinar technology consists of two parts. The audio is provided through a telephone conference line, and you can find that information in the bottom left-hand corner of your screen in the chat box. The visuals are provided through a web platform. If you have questions about the technology at any time during the presentation, please type them into the chat box on the left-hand side of your screen. You can also email Christina@onf.org, and that's CRISTINA@onf.org. We will work with you to resolve any technical issues as soon as possible. This webinar will contain opportunities for participation. There will be online polls, which you answer right on your screen, and a question and answer period at the end. If you have topic-related questions during the presentation, please type them into the chat box. During the Q&A, questions will be read out loud to the group. If you prefer to ask your questions over the phone, we will provide instructions to unmute your line during the Q&A at the end. The webinar is being recorded, and a YouTube link will be circulated to the registered participants in a week along with the presentation. I would now like to introduce our presenters, Susan Bonomo, Debbie Barton, Jessica Ng, and Jennifer Wright. Susan is a public health nurse with York Region Public Health. As a team lead with the Healthy Aging Services, Susan provides leadership and policy direction in fall prevention, targeting older adults 55 plus, including co-chairing the National Fall Prevention Community of Practice and chairing the Fall Prevention Strategy Committee in the Central Local Health Integration Network, or LHIN. Debbie is a senior manager with the Home and Community Care team at the Central LHIN. Since joining the Central LHIN in July of 2015, she has worked on several projects and programs, including the Fall Prevention Initiative. Jessica is a pharmacist with the Home and Community Care team at the Central LHIN. Since joining the senior management team in 2015, Jessica supports the professional practice department and Central LHIN's direct service teams by offering consultations for complex medical patients, providing medication management education, and developing and implementing clinical in-services. Jennifer is a senior manager, practice, education, clinical assessment and applications at the Central LHIN. Jennifer's key areas of responsibility include orientation, inter-RAI assessments, and applications and professional practice. I'm going to hand it over now to Susan, who will begin the presentation.
Thank you, Christina, for your introduction and for inviting us here today to share our story of collaboration. Good afternoon, everyone, and thank you for joining us. To provide some local context to today's webinar, the Central Local Health Integrated Network is one of 14 provincial health authorities responsible for regional administration of publicly funded healthcare services in the province of Ontario. The Central LHIN's boundaries comprise sections of Northern Toronto, a portion of Etobicoke, most of York Region, and South Simcoe County, with 1.9 million residents, the largest population of all of the 14 LHINs, the highest absolute number of adults aged 65 plus of all of the LHINs, a population of adults 85 years plus projected to increase by 59% in the next 10 years, overall population growth projected at over 17% in the next 10 years, the highest percentage of newcomers in Ontario at 49%, and as of 2015, Adults 65 plus accounted for 14.3% of the total CLHIN population, and by 2021, this will grow to 16.1%. And lastly, within the LHIN's boundaries, 3 public health units, Toronto, Simcoe-Muskoka District, and York Region, dedicated to protecting and promoting health and reducing inequities in health. Before we get started with our presentation, we have a couple of quick questions to ask you to help inform today's discussion. The first question, the first poll, is what sector do you work in? So if people could respond, and I see we've got pretty much equal numbers of public health, home care, and long-term care, with some from hospital and primary care, and the number from other, which I'm curious as what other is. But the majority, just slightly there, is in home care. Okay, so the next poll. The next poll is, does your organization have a fall prevention strategy? You can see the numbers predominantly are sliding towards yes. With some looking for some support in developing one, hopefully. Okay, and then the final question is, as part of the fall prevention strategy, has your organization collaborated with public health? And nice to see that a lot of you have collaborated with public health. Okay, great, almost half. So next slide. Today's presentation will speak to our collaboration and the continued efforts to build a sustainable fall prevention strategy, including our shared fall prevention mandate, the use of home and community care fall assessment and data reports, including the Resident Assessment Instrument Home Care, also known as the RHIN, or the RHI for short, medication management and fall data analysis, a least restraint approach to care, a collaborative education strategy, ongoing partnerships to develop local and regional strategies, and lastly, to wrap up, our key learnings, some recommended resources, and ending with an opportunity for you to ask questions. Next slide, please. For the purposes of today's presentation, a fall is defined as the unintentional coming to rest on the ground, floor, or other lower level with or without an injury. This definition of a fall is widely recognized and recommended in the Canadian Fall Prevention Curriculum, of which Vicki Scott is the lead author. During our preparation for today, we came across this statistic from a 2014 Falls Joint Report released by the Canadian Patient Safety Institute, Accreditation Canada, and CIHI, the Canadian Institute for Health Information, which we felt was relevant to today's discussion. Over 1/3 of assessed home care clients were at risk of falling, which represents more than 55,000 clients. The statistic is calculated for all community-based home care clients assessed with the RHI home care instrument. Next slide, please. This slide speaks to the scope of the problem and provides a compelling argument for fall prevention collaboration. In Ontario, in 1 year, falls in older adults led to over 100,000 emergency department visits, over 20,000 hospital admissions, $1 billion in direct costs, and over 2,000 lives lost. In Canada, 215 older adults are hospitalized each day because of a fall, and falls account for $3.4 billion in direct healthcare costs, 85% of injury-related hospitalizations for Ontarians 65 plus, and 95% of all hip injuries, fractures. Next slide, please. To provide you with some background to our story, collaboration with community partners has been an expectation of the Ontario Public Health Injury Prevention Standards, and to this end, York Region Public Health and Central LHIN have had a long-standing working relationship. That relationship evolved following the National Falls Conference in May 2014, when we were reintroduced through my involvement as co-chair with the Ontario Fall Prevention Community of Practice to focus on our shared fall prevention mandate. At the time, community care access centres across Ontario were developing and implementing fall prevention strategies to support home care quality improvement plans, and in public health, fall-related emergency visits in older adults 65 plus was a performance indicator and fall prevention mandated under the Ontario Public Health Standards. Our collaboration began with consultation on best practice resources, including Step Ahead to Fall Prevention. Jointly created by Toronto Public Health and York Region Public Health, this evidence-based training program utilizes current research, adult learning principles, and best practices to incorporate fall prevention into the participants' daily practice. We moved on to partner to deliver fall prevention education to patient services staff, focusing on best practice and screening tools as part of Central LHIN's organizational fall prevention strategy. In 2015, we shared our journey through the Fall Prevention Community of Practice newsletter, the Seniors Health Knowledge Network, the Ontario Association of LHINs Conference, and most recently a CCAC webinar, believing that increased cross-sector collaboration can break down silos, reduce duplication, and enhance health system integration to improve the overall health of older adults. Next slide, please. Now Debbie will speak to Central LHIN's Home and Community Care's Quality Improvement Plan.
Thanks, Susan. Central LHIN's multifaceted fall prevention strategy consists of a Falls Quality Improvement Plan, known as the QUIP, multifactorial falls assessment and intervention, fall prevention education, utilization of RI data and falls reports, medical equipment review, as well as development and updating of related policies and guidelines, including the least restraint policy. All LHINs create QUIPs reflecting the Ministry of Health and Long-Term Care's improvement priorities, including the reduction of falls in long-stay home care patients. Central LHIN's QUIP for falls has two primary goals. The first goal focuses on use of best practices in falls screening and assessment, and sharing results and follow-up actions that are taken by LHIN staff and contracted service provider organizations. Information is shared through client service reports submitted by service providers, direct communication between care coordinators and service providers, and through reporting risk-related events in Central LHIN's electronic quality reporting system. In addition, we recently implemented a falls notification pilot project to notify contracted service providers that a patient has fallen. An electronic provider notification is sent to all service providers working with the patient so they are aware of the patient's fall and can support the patient and family in implementing fall prevention strategies. The second QUIP goal focuses on identifying medications that may contribute to patients' falls. Jessica will provide more information regarding the identified medication trends. Next slide, please. This slide illustrates the percentage of reported falls based on follow-up RI home care assessments completed as of June 30th of this year. The average percentage of reported falls across all LHINs was 39.5%. Central LHIN's percentage of reported falls was 33.8%, which was the second lowest in the province. As previously noted, Central LHIN's quality reporting system tracks all risk-related events. A review of data from fiscal 2015-16 indicated that a significant proportion of the risk events reported were related to falls. This data, along with the RI home care data, helps us track patient falls and identify related trends. Now, Jessica will discuss the medication management analysis she has completed as part of our QUIP activities. Next slide, please.
Thanks, Debbie. It is undeniable that falls are dangerous for our patients and that the etiology of falls is multifactorial. In that same breath, one can say that medications are one of the most easily reversible risk factors in a comprehensive falls risk assessment process. As Debbie mentioned, my work has focused on the second QUIP goal of determining the effect of medications and their contribution to falls, and identifying and analyzing predictors of falls or trends relating to medication use. We reviewed literature focusing on medication classes and their potential correlation to increasing falls risk, and based on our empirical data, have been able to isolate key patterns in medication administration that may have played a role in a patient fall. Our aim is to extrapolate this information, to integrate it into practice, and ultimately help decrease the risk of falls associated with medication use. We hope to be able to use this information to create recommendations for our health service providers to proactively identify patients with increased risk of falling and reduce medication-related falls. Next slide, please. The baseline patient population for this work is derived from our rapid response nurse team's consultations completed between January 1st and August 31st of 2016. We analyzed empirical data focusing on 3 key factors. Number 1, the number of medications taken. Number 2, the classes of medications administered and their potential drug interactions. And number 3, the time of day the medication was administered. Next slide, please. Here, we are highlighting the drug-drug interaction arm of our
I think we might have lost our presenters. If you could just hold the line just for a moment, please.
Okay. Go ahead, Jessica. Okay. So sorry about that. Let's take it from the top of this slide. So here we are highlighting the drug-drug interaction arm of our analysis. Polypharmacy in and of itself predisposes a patient to drug interactions. Taking multiple medications at the same time may lead to additive or synergistic adverse reactions contributing to falls. Unfortunately, patient variability makes prediction of absolute effect difficult, so we focus only on harm reduction, prevention, and management. This chart shows the 12 most prevalent drug-drug interactions that presented within our patient population that are highly associated with harmful outcomes, particularly in older adults, if the dose is not adjusted or the drug interaction is overlooked. Here, for example, you can see that 104 patients out of 352 that were taking either an antidepressant and/or 2 or more central nervous system active drugs, and 102 patients out of 333 that were taking either an alpha blocker and/or loop diuretic were potentially experiencing a drug interaction. Next slide, please. From our data, we were firstly able to identify that polypharmacy is evident within our patient population. Polypharmacy is very common among the elderly, and though it can be therapeutic in nature, is linked to increased risk of falls due to increased risk of drug interactions, lack of adherence to medication regimens, and susceptibility of older people to side effects of medication. Analyzing our data, we found that the average pill load for our patients is 11 medications. Secondly, we've identified 14 key time of administration errors that may contribute to a patient's risk of falling. Optimal arrangement of drug administration schedules may lead to increased efficacy and lower incidence of side effects. For example, aspirin should be administered at bedtime, as the incidence of angina, myocardial infarction, and thrombolytic stroke is higher in the first 4 hours of wakening. And proton pump inhibitors used to decrease acid ideally would be administered at bedtime, as acid secretion is 2 to 3 times greater between 10 p.m. and 2 a.m., thus preventing patients from waking up with severe nocturnal episodes. Diseases such as asthma, allergic retinitis, cancer, cardiovascular disease, osteoarthritis, and peptic ulcers exhibit circadian rhythms in their occurrence or intensity of symptoms. Leveraging this information, we aim to develop suggested times of administrations for medications in coordination with the body's circadian rhythms to maximize therapeutic effectiveness and minimize and avoid adverse effects, ultimately reducing the risk of falls. Lastly, as previously described in the previous slide, 12 key recurrent drug-drug interactions that can increase the risk of falls for patients were identified. Drug interactions occur when the effects of one medication are changed by the presence of another. The effects may lead to additive or synergistic adverse effects contributing to falls. Side effects such as sedation, resulting in impaired balance and slow reaction times, as seen, for example, in patients taking antidepressants and other central nervous system active drugs. Low blood pressure, which can occur in patients taking multiple antihypertensive medications, and arrhythmias, which can be seen in patients taking various combinations of antihypertensive medications, antiarrhythmics, and/or potassium supplements, form the foundation for reasons why drug interactions may contribute to the risk of falling. We aim to be able to proactively identify these potential drug interactions and refer patients to the appropriate healthcare provider to decrease their potential in contributing to a patient's risk of falling. Now Jennifer will speak about the least strain approach to care. Next slide, please.
Thanks, Jessica. Now I will talk about our journey with the least restraint philosophy, an integrated part of our organization's fall strategy. Historically at the Central LHIN, we have had owned and rental regular hospital beds that range in height from 13 to 23 inches. In April 2014, the Central LHIN purchased electric glow beds ranging in height from 9.5 to 20 inches, and falls mats to provide more options to home care patients at risk of falls or bed injury. In January 2015, after our initial staff fall prevention education, the least restraint policy was introduced with additional education. And by July of 2015, we were realizing the extent of our need for low beds, as staff were becoming more familiar with options for patients. Starting in March 2016, a new contract was negotiated to include more owned electric low beds and the ability to rent electric low beds and falls mats, sharing a rental pool of beds between 6 LHINs, providing more options for home care patients. We wanted to highlight in April of 2017, Health Canada posted a safety alert on hospital beds, risk of patient entrapment. In this safety alert, it reports there has been 58 incidences of patient entrapment in hospital beds, including 11 deaths from August 2012 to March 2017. So this reinforces our need to focus on patient safety. At present, we know the culture is changing as more patients have decided to purchase or continue renting the electric low bed with a falls mat for ongoing care needs, and our utilization increases for low beds. Next slide, please. As our utilization of low beds has increased, you can see from July 2015 to present time a significant decrease in our usage of full and partial rails. Staff are more aware of exploring options with patients to support our least restraint philosophy and approach to care. Next slide, please. This is a sample report we use to review utilization of full and partial rails, using this information from the RHI home care and equipment ordering. Starting at the top, you will see a summary by team and total number of patients and total number of therapeutic mattresses. From the left of the detailed report, we have a link to the patient's health record, hospital hold alert, which will email if a patient's on hospital hold to trigger a review. This has been an effective strategy to reduce the number of patients with full rails in place as exploring alternative and safer options. Then item code, mattress type, the assessment date, CHESS, PERS, the pressure ulcer risk scale, and MAPLE, and next the number of falls and physical restraint use, and next the rental start date and the number of days since ordered. As we identify any potential risks, Debbie or myself will contact the care coordinator to clarify rationale and ensure all alternative options have been explored. This report is part of the community manager standard of work for sustainability. We have email alerts for any new orders and recently added the hospital hold alert. In addition, this report has been able to identify education needs, not only for our LHIN staff with assessment coding, also for our service provider organizations and hospital sites as we review ordering and rationale. We have provided additional education to focus on our LHIN least restraint policy, our equipment manual, to ensure understanding and awareness of options for home care patients. This has made a significant difference in practice, and our utilization continues to decrease. Next slide, please. This is our newest report that has just been created to assist in tracking and monitoring the utilization of rental and owned low electric hospital beds. It is set up similar to the other report by team summary, and we can review the number of therapeutic mattresses, assist rail, and fall mat usage. In addition, it has patient-specific information from their RHI assessment information. It will help to better inform practice and needs as we continue our efforts to support patient safety. Next slide, please. As you can appreciate, to impact the outcome for home care patients, it is not just one approach. It is a multifaceted and ongoing collaborative education strategy using a variety of methods and resources. Starting from the left top circle, York Region Public Health Healthy Aging and Fall Prevention website and the Central Healthline's dedicated fall prevention webpage provide up-to-date resources, programs, and best practices for use across the health continuum. Additionally, work is taking place towards standardizing key fall prevention educational resources used by the Central LHIN contracted service providers. We have dedicated intranet pages for fall prevention and medication management and service provider extranet pages. We have care coordinators who are champions within the teams as they have attended advanced fall prevention education, the Step Ahead to Fall Prevention through Public Health, or completed the Canadian Fall Prevention Curriculum. All home and community care staff received education on the least restraint policy and approach to care. Home and community staff completed a recorded webinar and then attended a follow-up case study review and discussion education. We leverage RI data at the team and caseload level for reflective practice and to support critical thinking, as it reviewed how many patients have had a fall, the number of falls, and use of restraints to reflect on practice and challenges in addressing patient safety in the community. This was an important piece in changing the culture and buy-in on addressing fall prevention and least restraint philosophy, how to get the attention and keep the attention on this approach to care and patient safety. For sustainability, we leverage the National Fall Prevention Month held in November. This is led by Partners for Fall Prevention Month. You will see this resource as we move ahead in the presentation. As part of our annual refresher, we have LHIN and service provider organizations joint video and a professional practice scenario. The short video is one step, and the second is a professional practice scenario, a 15-minute presentation, and recorded webinar for sharing. Last year we featured a patient story with a focus on falls and least restraints, reinforcing the need for ongoing assessments by the care teams. As you can see, our strategy is multifaceted and continues to evolve to improve outcomes for home care patients. Debbie will continue with our collaborative partnerships. Next slide, please.
Thanks, Jennifer. Central LHIN's home and community care team collaborates with hospitals, group homes, and long-term care facilities to share resources and provide fall prevention and least restraint education. We work with our contracted service provider organizations to update the fall's QUIP plans, develop educational webinars for staff and service providers, and implement fall prevention and least restraint initiatives, including the Falls Notification Pilot. This pilot project, as previously referenced, focused on sharing information regarding a patient's fall with all members of the patient's care team. Feedback from care coordinators and service providers indicated that the notification process helped enhance awareness of a patient's risk for falls and the need for ongoing education. Recommendations are currently being developed in follow-up to this pilot. In addition, we are examining tools and strategies to assist care coordinators and service providers in assessing a patient's need or candidacy for bed rails and the most applicable type of bed and/or bed rail to promote patient safety. Central LHIN is a member of the Interprofessional Healthy Aging Working Group led by York Region Public Health. This group focuses on promoting healthy aging and fall prevention education for older adults in York Region. We also work with community programs providing group exercise classes and fall prevention programs across the Central LHIN. Central LHIN staff and care coordinators refer patients to these programs and complete RI assessments to better understand the participants' abilities and needs. Next slide, please. Since 2015, guided in part by the Integrated Falls Prevention Framework and Toolkit released in July 2011, both Central LHIN and York Region Public Health have collaborated with multiple organizations, including hospitals, service provider organizations, and community agencies, to deliver fall prevention education and promote best practices in support of a Central LHIN-wide integrated fall prevention strategy. In May 2015, York Region Public Health led a group of stakeholders from the Healthy Aging Working Group through a roundtable discussion on the social determinants of health and falls in older adults. The stakeholders came to the consensus that a fall prevention strategy was one of the best ways to address the social determinants of health and falls. As a result, the Fall Prevention Strategy Committee was formed to investigate, develop, and promote a central LHIN-wide integrated fall prevention strategy which targets older adults across all sectors. The purpose of the Fall Prevention Strategy Committee is as follows: to centralize best practice resources and facilitate dissemination of information to community partners and community-dwelling older adults, to increase awareness of factors that contribute to falls, to create opportunities for stakeholder engagement, capacity building, and knowledge exchange, and lastly, to coordinate, develop, and implement a central LHIN-wide integrated fall prevention strategy. Over the past 2.5 years, the committee members have dedicated time and energy to the following activities: providing outreach to over 175 stakeholders, to facilitate creation of new organizational profiles or updating existing profiles on the centralhealthline.ca. Also, creating a dedicated fall prevention webpage on the Central Healthline, which was previously referenced. The webpage, launched in April of this year, aims to provide the public with easy access to information regarding exercise and fall prevention classes, fall risk assessment, management and treatment services, information, education, and related resources. Also, the committee has analyzed information gathered from the outreach activities, individual and group consultations, an environmental scan, and a literature review to conduct a preliminary gap analysis and then draft a report of the findings. The committee is planning an upcoming roundtable event in November of this year for stakeholders in each of Central LHIN's public health unit areas, which includes Toronto, York Region, and South Simcoe. The purpose of this event is to share the preliminary findings of the gap analysis report, seek validation of these findings, and request additional input and engagement to further develop the LHIN-wide fall prevention strategy. Next slide, please. As Jennifer, Susan, Jessica, and I reflected on our fall prevention activities, we agreed that essentially everyone interacting with a patient and family has a role to play in fall prevention. That can include a personal support worker, a neighbor, an occupational therapist, physiotherapist, the superintendent of a condo building, hospital staff, friends, and others in the individual's network. Together, we can promote fall prevention strategies, provide fall prevention education, and help an individual and family implement specific options to reduce injuries from falls. One of those options may include use of an electric low bed and falls mat. Fall prevention education requires a collaborative and integrated approach to effectively support individuals and families, particularly as a person's needs and health status changes. Building on our collective experience and use of shared best practice educational materials, we can expand knowledge and skills in fall prevention and promote integration of best practices across sectors. And lastly, but certainly not least, is the recognition that falls may not be prevented 100% of the time. However, the impact of a fall on a person's health status and daily activities can be mitigated by ongoing education and use of individualized strategies to help reduce injury. Next slide, please. Moving forward, Central LHIN's Home and Community Care team will continue to use RIDATA, falls reports, and least restraint data to inform practice, guide policy development, and identify process adjustments as part of our organization's fall prevention strategy. This data will also assist us in designing fall prevention education and training to support LHIN staff and service provider organizations. As part of our annual QIP planning process, we will engage staff and contracted service providers in identifying change ideas and process improvements related to fall prevention. We'll continue to promote patient awareness and increased access and referrals to exercise classes, fall prevention programs, and related fall prevention and intervention services as part of our education and intervention strategies. And lastly, the Fall Prevention Strategy Committee, led by York Region Public Health, will continue working with key stakeholders towards gaining a fuller understanding of the current status of fall prevention activities across Central LHIN, with the ultimate goal of creating a truly integrated fall prevention strategy across Central LHIN. Next slide, please. This slide identifies several online resources that were previously referenced. We encourage you to explore these resources as you consider the next steps in your fall prevention strategy. Also, we wanted to identify that the Registered Nurses Association of Ontario just recently released their best practice guidelines for falls, which is entitled Preventing Falls and Reducing Injuries from Falls. And this is the third edition of the best practice guidelines. So now this concludes our formal presentation. Next slide, please. We've included our contact information for your reference, and we are now ready to take questions.